Our crowd, both the live in-person people and the virtual people. My name is Gideon Orbach. I'm joined here by my esteemed colleague.
My name Phil Ross.
Both of us practice chiropractic here at the World of Wellness. And we're having a long overdue conversation
Yes,
that
we
everybody gets
are.
to eavesdrop on.
Absolutely. I've
talk-
been here 2.5 years, and this is the first time we actually got the same time, and we're gonna kind of have a little conversation here.
Way long overdue. So the topic of our conversation is stretching.
Yeah.
That's what the brochure said.
Yeah.
But let's expand this a little bit.
Okay.
Now, speaking from my own experience, and I know, look, you've treated me. I've seen the way you treat some of your patients. I mean, you're doing your thing all day long. I'm doing my thing all day long, and once in a while we get a chance to watch one another. Just let's learn something new.
Absolutely.
So I say this speaking for myself, but I suspect that I'm speaking for you too. So then let me throw out the disclaimer in front of our full crowd and our virtual crowd and everybody involved. Cut me off. I mean, you speak for yourself, but until you do, I'm speaking for you too.
Perfect. Okay.
So I like to treat my treatment style means doing hands-on treatment for patients from head to toe. We're not so concerned. I mean, look, something like I hurt my shoulder, I hurt my knee. I mean, like I'm not blowing you off, but my concern is for your systemic body musculoskeletal function, not for isolated parts that don't feel good.
Mm-hmm.
So we're looking at people from head to toe. And when I make my initial evaluation of a patient, I'm thinking like there are 24 places in your body. I mean, in your multiple parts of your spine, multiple extremity joints, multiple places in each foot. There are at least 24 places where I could justify adjusting you.
Absolutely.
And when you think about the neurological input of a high velocity, low amplitude, hands-on chiropractic adjustment, nobody should be adjusted at 24 places.
Yep.
I mean, it's just I don't want anybody doing that to me.
Yeah.
I'm not doing that to anybody.
Yes. A lot of stimulus.
Right. So
Yeah.
let's lower that down. Let's dial that down, and let's make a distinction between what are the primary places that like this is real dysfunction,
Mhm.
and this is going to be symptomatic or compensatory dysfunction.
Mhm. Mhm.
So when I make that distinction, I like to do a lot of stretching technique with my patient population, and when the stretching technique, it's a standalone technique. It's proprioceptive neurofacilitated stretching can be explained as assisted stretching, where I'm going to take care of neurological reflexes to allow you, the patient, to stretch further than you're otherwise capable of.
Yeah.
Okay.
Those three big words that Dr. Orbach just said, we could even just call it kind of like contract, relax, stretch.
Sure,
if you will,
absolutely,
as well.
absolutely.
Yeah.
I mean, we could call it. I mean, the same technique has a number of different names.
Correct.
So let's my personal vocabulary is PNF, but we can call it strain, counter strain, or contract, relax.
Yes.
It's the same thing.
Yes.
And so I was running an errand in Shadyside the other day, and I parked my car, and as it happens, I parked right in front of a wellness center, and there's a list on the window of all the things they do, and this half a dozen different forms of therapy that I've never heard of. I don't know what it is. I mean, it sounds fancy, sounds great. Have at it. And the last thing on the list is assisted stretching,
Mhm.
and there are businesses and clinics popping up all over the place where they're doing assisted stretching, and really flexibility. It's a buzzword, and
Yeah.
as people age, losing their elasticity and losing their flexibility it's a big deal.
Yes. Yes, it
So
is.
we want to help our patients, and through these stretching techniques, like I don't know what they're doing at this place in Shadyside, but I know that for us, our scope of practice is broad. If they had a chiropractor on staff,
Mhm.
it would have said chiropractor on staff.
Yes.
And
Yes.
and so I'm imagining a scenario where there's a very well trained massage therapist or athletic trainer stretching people out. And now our broad scope is minor league compared to a medical doctor, but major league compared to what you see at these stretch centers.
Mhm. Mhm.
So I look at stretching as we're accomplishing two things. One, it's a legitimate technique. We're helping our patients prevent from becoming stiff and ratchety, and we're increasing their flexibility and literally stretching them out.
Yeah.
But I also look at it. We take this a step deeper. That when we're doing stretching at the PNF or the strain counter strain or the contract relax,
Yep.
we're also using that as a diagnostic tool in
A-
order to determine, is this a primary area of restriction or is it a compensation?
a- Absolutely. So, yeah, the place down in Shadyside, there's one in the South Hills and North Hills as well. I would have to say that's I've actually went one time. It's kind of like a cookie cutter approach. So
Mhm.
if you come in and hey, my legs get tight after I go run or after I golf, my low back's tight. They're basically just going to go cookie cutter. This is this is what they're coming in for, and this is what we're going to do for everybody. What myself and Dr. Orbach do is there's multiple ways to skin a cat, so to speak. So we're talking about stretching. There's probably 3 or 4 different ways that you can actually isolate and treat the soft tissue of an upper trap. So if I have a patient based on their range of motion, I might treat it one way and I might treat another patient a different way. So just like what Dr. Orbach's saying, just to piggyback off of it, we kind of use it almost as a diagnostic tool to kind of see if it's coming more from like a joint or if it's actually coming more from the muscle. And just my philosophy too is obviously being a chiropractor, we're going to instill motion into a fixated segment. So in my opinion, and Dr. Orbach, you could comment on this as well. If you just come in and just a regular chiropractic appointment and we just adjust you, yes, you're going to feel better, but we're basically missing 50% of it. If we instill motion into certain joints in your neck, but we don't work on the tight structure, like the tight soft tissue, whether it's the tendons, ligaments, or muscles that are attaching to these joints, you're missing half the battle, right?
Right, exactly. That we want to think about musculoskeletal system as a big game of tug of war, where the muscles are pulling in one direction, the joint is pulling, or the skeleton is pulling in another direction, and where two bones come together, we have a joint. So we have skeleton pulling here, muscle pulling this way, and the tendon is kind of like the rope in between. So if we have good symmetrical pulling between the skeleton and the muscle, that person is going to be able to move through space comfortably, like a well lubricated gear shift.
Yes. Yes.
And if we have asymmetry between muscular pulling and joint dysfunction, then all of a sudden people are moving in a ratchety, uncomfortable, maybe painful, yeah,
Compensated.
compensated,
Yeah. Yeah. Just a
and then that complicates the ability to stand up straight and have good posture. That complicates the ability to breathe deeply. That complicates the ability really to participate in all your normal daily activities of living.
and you're not reaching your full potential as well. But
Exactly.
like
Exactly.
when patients come in, I'd like to say, if you're coming in for pain, that's one thing, right? We're going to get you out of pain. I'm not even worried about that because that's going to be
Yeah.
relatively easy for us. But what do you want to do that you can't do? Like,
Mhm.
I love just basically trying to make people perform as optimal as they can. And I said this prior this week when I talked about it. If you want to be able to get on the ground comfortably to play with your grandchildren and get up and not have to worry about, oh crap, tomorrow I'm going to be feeling it,
Yeah.
like
Yeah.
I truly just want to improve your quality of life so you can do what you want to do and live the life you want to live. And not only does adjusting help, but I mean the stretching, the soft tissue therapy. I mean
Absolutely.
that's right there up there with it. Yeah.
Absolutely. Yeah. Well, to your point, I mean, when you talk about people's potential and you talk about people's function and how are we going to enhance that, and you think about, well, do you have a retirement savings account? Are you putting away money for a future? I mean, this is part of the equity that you're going to put into your body for your future,
Correct.
and we see, I mean, us here, but chiropractors, physical therapists, massage therapists, physicians of all specialty across the world. I mean, with aging comes a loss of strength,
Yep.
and it comes a loss of flexibility. And if you want to protect yourself against that loss of strength, I can't go to the gym for you.
Yeah.
I can't do resistance exercise for you. God knows I do enough of it for me, and I really enjoy it, and I'd like that to be contagious, and I want everybody who I encounter to take up a resistance exercise program. But I know that's not the case. But the flexibility, that's something that we can do partially for you and partially teach you how to do for yourself.
Absolutely. And I guess we could start with one of the most common things, which we could kind of piggyback on flexibility too, is there's something called upper crossed syndrome. I don't know if anybody's heard about it, but it's essentially, I call them desk jockeys. So if you're working from like, basically like a computer anywhere from 40 to 50 hours a week, what happens is certain muscles turn on too much and then they get crazy tight and then it's going to kind of pull your body out of whack. So essentially what upper cross syndrome is, your pec minor would get tight. So everything we do in society is always in front of us, right? Forward flexion. So whether we're eating, driving, working on the computer, playing with your phone, everything's always in front of you. So your pec minor gets really tight. And what's going to happen is going to roll your shoulder forward. And then your deep neck flexors turn off, and then your upper traps turn on. So basically, certain structures are basically too tight, so they're hypertonic, and then it's going to pull everything else to the whack, and that's definitely going to compromise your spine as well.
That's right. That once again, we want to look at this as that great big game of tug of war. And if we are practicing desk jockeyness, and we're sitting here typing or leaning into our computer, or maybe we're leaning into the steering wheel, there's not much of a difference there.
Yep.
You can see these muscles in the top front part of the shoulders and chest. They're gonna collapse in here. They're gonna round in,
Yep.
and that's gonna create strains. Think about it's called an upper cross. So let's get away from the vocabulary and just think about an X.
Mhm.
That the top part of the X becomes tight, rounded in, dysfunctional,
Mhm.
and the parts of the X across your upper middle back start to fatigue. They start to lose their function. They start to be recruited to do more counterbalance than they're planned on or that they're designed for.
Yep.
And then we start seeing this situation where the upper thoracic, the thoracic spine is a part of the spine that's characterized by having ribs attached. So let's think about the bottom of the neck to the top of the lower back. So the top third of the thoracic spine starts to compress in like so, which means that our rib cage is not expanding and compressing when we breathe.
Correct.
It means that these muscles right in here, they're called the accessory muscles of respiration. They attach to the collarbone and the top of the rib cage, and they're going to be used as a pulley system to lift this up with breathing.
Mhm.
That shortness of breath, you can almost go to the bank that that's going to start to cause headaches.
Yep.
And
Yep.
As we sit here, we're painting a picture of the majority of our patient population.
100%. And so when people are coming in, hey, I got some mid back discomfort, pain, I just feel tight, I feel locked up. I've been to other chiropractors, I got adjusted, I feel better temporarily, but I never get the full fix. Well, because you're missing half the battle until you turn off this. So essentially, when you're sitting all the time, pec minor gets tight, your shoulder's going to roll forward. What happens to the back? There's a ton of tension on all the muscles on the back. So if you get adjusted, you're going to feel great temporarily.
Yes.
But if you don't work on the tight muscles, basically putting you in that compromised position, you're never going to make a full recovery.
No. So that's where our strain counter strain or PNF, proprioceptive neurofacilitated or active isolated stretching comes into play. Now, when you think about the rounded in shoulders and that strained upper middle back area, like we have at least half a dozen different vertebra. Each vertebra has two ribs attached to it, the collarbone, uh, um, the joints of the shoulder blade, the scapula, the wing, and the back,
Mhm.
and how it interfaces with this is called the humerus, the upper arm. It has a ball and socket characteristic with the shoulder blade. So right there off the bat, where we just picked out 15 different places to adjust somebody,
100%.
all within about this much of an anatomical space.
Yes, correct.
So
Yeah.
how do we make a decision as well? What should we adjust, and what should we assume will fix itself if we adjust properly?
Mhm.
And that's where the stretching comes into play.
Yeah.
So if we think about technique, chiropractic technique as different categories, there's fast and there's slow.
Mhm.
Slow would be like a long, gentle, sustained stretch where we're working on a whole entire muscle. But slow could also be working on a trigger point
Mhm.
where we're only working on one tiny little focal point
Yep.
within that muscle.
Yep.
So as I know you do at least as much of this as I do, probably more. I mean, you have the instrument assisted. I mean, that's a big part of what you do.
Mhm.
So that focal point in a muscle,
Yeah.
that it's crazy. It's super tender place.
Yep.
And when you feel the patient kind of squirming and
The
trying
face
to find,
shows it all.
Yeah, the face says it
Yeah.
all. You that's when you know you're in the right place.
Yes,
And
100%.
then when they tell you, I feel it traveling down an arm, and
Yep.
I feel that traveling up. Like then you doubly know you're in the right place.
We're in it. Yep.
And then they say, I don't feel it anymore. And then you know you did a good job.
Don't let this man fool you though. Yes, I do use that instrument to work with it, but I've had a long history of shoulder issues, and his thumbs they find places that are very uncomfortable. But as soon as I'm done
I
with
take
it,
pride in that.
yeah. But as soon as he's done working on me, I mean, shoot, yeah, I just long story short, two surgeries on my shoulder, a couple decent amount of dislocations, and yeah, like my shoulder will get jacked up once in a blue moon. And where am I going? Right to his room. Because you have tight muscles that are basically locking everything down, restricting my range of motion. Everything's going to compensate my body, and this guy gets me right.
Now here's the counterintuitive thing. Dr. Ross is talking about having had shoulder surgery and aches and pains and dysfunction in his shoulder. So let's drill down on this for a second. If he had, I'm talking about you like you're not even here. You've had this shoulder surgery.
Yeah.
Wouldn't it stand to reason that shoulder is one of the more stable places in your body now?
Yeah.
So
yeah.
why would it hurt? What's that all about? You would think that the shoulder would be the most stable part of his body, and it probably is. Musculoskeletal wise, he's a pretty stable guy. But all these aches and pains and all this dysfunction, it comes from the fact that the tug of war is off.
Yes.
As the shoulder becomes more stable, as it becomes more not restricted in its place, but less range of motion.
Yeah.
It's going to recruit the musculature to pull harder in order to keep up with that stability.
And then if you don't get that corrected, you're going to slip into a negative feedback loop. You
There you
know,
go.
kind of like what the upper cross syndrome is, right? We were talking about that big X.
Mhm.
When one thing goes, another structure is going to have to pick up and get some of the delegation of the forces, so to speak. And then you just have a negative cascade. And so I usually recommend patients if if I got patients who come in maintenance wise as well as you do,
Sure.
and I always tell them, look, you know your body better than me, and Dr. Orbach says it the same. I love to get adjusted at least once a month. I
Yeah,
wish it was a
it's
little bit more frequent. But if you start to feel any little thing kind of go out of whack, or a little bit of tension that you haven't been experiencing, or just a little bit of an ache, you better get in sooner than later, because if you let that
Exactly.
fire go, it's going to start as a little flame that's going to go into a burning fire, and then that's a way bigger fish to fry treatment wise.
Well, you bring up a very important point. And when I think about my patient population, they're people who have acute injuries and they're coming in like, this is the immediacy with a sense of urgency.
Yes.
But the overwhelming majority of my patients, I think about them more as maintenance.
Yes.
And some people have maintenance sporadically.
Mhm.
Some people have it. Look, I'm coming in every month or every 2 weeks or whatever their interval is. Like it's a part of their religion. And some people come in like twice a year and call it maintenance, and that's fine. That we don't demand that people stay on treatment plans. We don't do contracts. We don't do long-term care plans.
Mhm.
But I joke around about like, well, I'm pressing on that trigger point or that tender tight spot, and it was traveling down the pinky finger, and then now it's not traveling anymore, and it feels so loose, and that's how I know I do a good job.
Yeah.
But what really, really influences me to know that I'm doing well with patients is when they don't need me to tell them when to schedule.
Yes.
That your body will throw out signs.
Correct.
That maybe if somebody has had an injury that never healed to 100%, it healed to 90%. And what 90% means to me is that they're 100% functional, they're fine, they're great. It just takes a lower threshold to aggravate that injury or to cause it to reestablish itself. And when they have that, oh man, my shoulder's doing that thing again, I better schedule to get in. That's when I know that I've properly explained what we're getting at and made the right impression on the patient for them to understand what is it that we're really trying to do here.
Yeah.
So
Absolutely.
that's a big one for us.
And just sitting here is kind of funny. So it's funny because me and myself and Dr. Orbach always talk about great posture, right?
Right.
And then I sit like a Neanderthal at the end of the day, cranking on my computer, doing notes.
Right.
And now since we're talking about this, I'm trying to sit up a little bit more upright.
I'm doing the same thing.
Same exact thing.
You have my attention, and the
Yeah.
camera has my attention,
Yeah.
and I'm sitting in a way that I really can't see the people in the crowd. I'm trying to glance over at them, and I see them making efforts at standing up straighter. It's a sort of a contagious thing that that, oh, we're amidst the chiropractors, let's sit up straight.
Right. That's actually kind of funny.
Yeah.
Yeah. And then what do you think?
We use our influences for good,
right?
for good only.
And so I guess if we talked about upper cross syndrome, we might as well dive
Yeah,
into lower
absolutely.
cross, right?
Absolutely,
So,
sure.
and when we were talking about how if you have tight structures, it's going to basically delegate tension and pain to other places. Very, very, very common one. 10 years ago, everybody said sitting's the new smoking.
Right.
Basically, what they were trying to get across is a lack of motion. And I like to say this with patients: movement's medicine, motion is lotion. When you stop moving, stuff's going to deteriorate very, very rapid. But
Yes.
long story short, the more we sit, there's something called a psoas muscle. And your psoas muscle attaches not only to like the vertebra in your low back, a couple attachments actually to the disc as well, and then actually goes through to the front of your hip. And the psoas muscle, in my opinion, if you don't treat that, is what, like if you have a patient coming in with low back pain, or anybody sitting at home listening, if you have low back pain and no one's touched the front of your hip or just your psoas muscle, you're not going to make that 100% recovery.
Right. Let's drill down on that psoas for a little bit. If you think about where it's located, the psoas start
my spine.
the psoas attaches to the front of the vertebra in the low part of the back, and it attaches to a little bit wide of the vertebra, so it's going to have overlapping attachment on the disc. So if we go to approximately the height of the belly button, and we take a cheese slicer and just start cutting off layers, the last muscle we get to before we get to the spine will be the psoas.
Correct. Very internal, very deep.
It's deep. It's not pleasant to have worked on
at all.
But the action of the psoas is such that we're marching. That if your thigh is coming closer to your chest, that's psoas pulling your thigh up. So if you're sitting on a high chair like we are now, we're in thigh flexed position. So the stool might be bearing our weight, but the psoas is shortened to hold our legs right where they are.
Time after time, driving, eating, sitting on the couch, it's always under a state of tension.
Absolutely. Yep. So because of the anatomical location of the psoas, we would call it a back muscle, but it's in front of the spine. So it's tricky. It's tricky to get to, it's tricky to reach. So I wonder, I have no idea how to attach a percentage to this, but I wonder what percentage of people out there complain of lower back pain, but their lower back pain is driven by tightness in one or both sides, both psoas muscles. And if we do stretching techniques, the strain counter strain, where we think about the hip being the joint where the thigh meets the pelvis, as a pendulum. So as we sit here, our pendulums have come forward. We want to stretch in such a way to bring our thigh to ratchet it back behind our body, almost like you're taking a giant step backwards. How many people would have lower back pain that, if not resolve, at least show marketable improvement simply by stretching and loosening up the psoas muscle?
1,000%, because not only is that tight psoas muscle going to be a pain generator, it's going to throw off your anatomical position. So as to piggyback off of Dr. Orbach, it attaches to the disc in the lumbar vertebra, so the bones in your low back, and then it attaches to the front of the hip. If you have a very hypertonic or tight psoas, what's actually going to happen is it is actually going to dump your pelvis the wrong way that you want it dumped, and then it's actually going to load a couple other structures in your low back. One of them, talking about lower cross syndrome, is going to be, it's called your erector spinae. Erector spinae, just very general, it's the two muscles along your spine. It's like the main spine stability muscles.
Right.
And they're going to take more tension.
Well, the erector spinae muscle group, we can't take that lightly. If you remember back, probably in the early 2000s, there was an exhibit called The Bodies, where these
that was cool.
That really was. There were cadavers that had been dissected out that were traveling the country in glass cases, so that you could see the musculature, and you could see the where is part A relative to part B, and if you pain right here. Why might I think that? Why could that be kidney? But why could it also be lumbar multifidus? And
Yes.
look how close these structures are. And so, I mean, I know you dissected more cadavers than you want to admit to, and
Yes.
as did I. And that's what you do when you go through
Yeah.
chiropractic school. But
Uh,
for people who have a fascination with the human body that never took gross anatomy,
yeah.
what an amazing exhibit this was.
Oh yeah.
And when you think about the cadavers that we saw, how magnificently well and artistically well they're dissected out by probably by professional dissectors and surgeons and
Yeah.
anatomists,
Yeah.
how physically big those erector spinae muscles are,
Thick.
and
Yeah.
even on untrained, non-athletic, small people. I mean, these are big muscles. These are very big muscles. This is where we hold a lot of our muscular mass,
Yep.
and this is where we use these muscles to warehouse and to protect the spine, and to move the spine, and to stabilize the spine, depending on which range of motion you're in.
A lot of moving
So,
parts. Yeah.
so we have the psoas muscle group in the front that's spasmed or tightened or is causing us dysfunction, and then it triggers erector spinae musculature
Mm-hmm.
contraction, and the erector spinae run from basically from the skull to the tailbone.
Mm-hmm.
So
Correct.
you think
Yeah.
about all that anatomical real estate that becomes vulnerable to aches and pains and dysfunction and tightness, and this is where we become detectives. That our it's you point to a place that hurts, and you can't treat that point.
Yep.
What caused this point?
And just to piggyback off Dr. Orbach too, he was talking about how big of how dense that tissue is, the erector spinae muscles, and they start on something called your app. We could just say right above your tailbone, and then they actually split into three, and then attach to your skull.
Yeah.
Since those muscles are so big and thick, unfortunately, if you let that fire, that small fire, just oh, I felt it again, let me let it go. Oh, I felt it again, I'll let it go. If you have something going on with that erector spinae muscle, that takes a decent amount of treatments to kind of loosen that muscle up, just because how thick it is and how strong that muscle is.
That's right.
Yeah.
That's absolutely right. And it's not a difficult muscle group for us to work on,
Mm-hmm.
but it's a pretty difficult muscle for somebody to stretch on their own.
Yes, correct.
And I think that the erector spinae group is a perfect example of where are we going to have strain, counter strain, PNF assisted stretching
Yep.
to work the whole muscle in and of itself at once, versus let's find the individual trigger points and work on those slow sustained holds. That goes much better for that group of muscle.
And I think that's where we differentiate ourselves from, these other different places you could go and just get stretched, hey, $30 or $50 for a half an hour stretch, is because, not only are we going to do the PNF stretching, trigger point work, I like to do something called pinning and stretching.
Yeah.
So pinning and stretching essentially is I guess I could show you real quick with my pec minor. So we were talking about the upper cross, right?
Mhm.
So what happens is your pec minor gets tight and it's going to roll your shoulder forward. So just if you're working from a computer, if you're doing anything, spending a lot of time working in front and that pec and your shoulders are rolling forward, very simple. You could go arm right in front. And then like Dr. Orbach was saying, you could kind of palpate, feel around where you feel, ooh, that's a spot. And so your pec's short right now, and then you're going to pin it, and then you're going to stretch it. And if you're looking at home, and if you try and do this at home and you guys sitting here right there, you feel that.
Oh, yeah.
You feel that. And I just think you get a little bit more bang for your buck if you're going to work on a muscle, if you do some of the things like the PNF stretching or the trigger release. We could call it pin and stretch.
Yeah. We're going to have like a dance class now that everybody's going to do some pinning and stretching.
Yeah. Yeah. But it truly does go a long way. And, there's so much.
Okay. This is the beauty of having live presentations and people back in the building. I think we're living in a post-COVID world.
Yeah.
You just never know what becomes available. And we have an offer to bring in some polka music to do our dance class.
There it is, right? Yeah. Yeah, but so like I guess the point we were trying to get across is it's nice to have a slow, sustained, passive stretch, right? But I just, both what myself and Dr. Orbach do is, we're gonna we're gonna diagnose, we're gonna play detective, so to speak. Right. We're gonna find what needs worked on, and then not only are we gonna potentially passive stretch it, but when we go through the active stuff, so the PNF, contract, relax, stretch, pin and stretch, you're just going to get a lot of more bang for your buck. And
Right.
then myself and Dr. Orbach, very well versed with the human body, obviously. So, hey, that felt great. Is there anything I could do at home? Absolutely.
Yeah.
So come on, and then
Yeah.
we'll give patients. I'm a huge advocate of homework. There's only so much we could do in a treatment. Once or twice a week, every couple weeks. So you got to do your stuff at home as well.
Yeah. Yeah.
Easier
Always
said than done.
right.
Yeah.
Right. I mean, we have what I've learned over the years is I wait for patients to ask, what can I do for
Yeah.
myself? And I want 100% compliance.
Yeah.
I'm not going to get it, but that's what we're striving for.
Yes.
So if I find like we're wrapping up the session, I'm thinking to myself, I got 2 good stretches for you. Just come on, say something, please.
Yeah.
Make a commitment to this, please.
Yep.
And if the patient says, "Is there anything?" Yes, says, "I'm glad you asked."
Actually, yes, I do.
Right.
And I always give patients, same 2, 3, up to 5 stretches or exercise they could do at home. And very, very common when, hey, did you try those since last time I saw you? Oh, I forgot. Well, bring your dang phone in.
Right.
You can take a video of me doing them, and then
Exactly.
you can't forget them. Is what I like to do as
That's
well.
such a good point. I mean, everybody has a phone with a video these days, and
Yep.
let's start making movies. So
Yeah.
you make it like the picture.
Because
you can have now you can go
There
home
it
and do
is.
dance class without me.
yeah, but just because there's only so much we could do in a treatment room, and not only makes our job a lot easier, but you are going to feel way better, and you're going
Right.
to be able to function as optimal as you can if you take care of yourself at home. I can't get that point across
Right.
enough.
I refer to that as bet on yourself time.
100%.
That I'm gonna give you everything I can, but we're spending a long 20 minutes, a short half hour together,
Yeah.
once every week at the most, once every couple months,
Yep.
infrequently. And what are we doing in between to reinforce
Yeah.
what we're trying to achieve here?
Yep. Food for thought.
So,
Yeah.
and when patients tell me like, all right, look, you asked me, so I told you 2 stretches and exercises.
Yeah.
And then you come back and I said, well, what have you been up to? And they're like, oh man, I was in the garden for 4 hours. That's wonderful.
Yeah.
What about the 2 things that we talked about? Conditions. Well, I went for a walk. That's wonderful. What
Yeah.
about the
A little yin
Yeah.
with the yang.
Right.
If you're
There
going
you
to
go.
compromise your body in the garden
Yeah.
for a couple hours, undo everything you just
Right,
did
at
after.
the opening? Exactly.
Yes. Yeah, absolutely.
Exactly. So let's move on. Let's spend a couple minutes just showing people what this looks like.
Okay. Okay.
We're gonna have IT savant Phil, who makes all the technology around here happen. Go maybe a little bit mobile with the camera, and why don't you do like 1 or 2 of the stretches that you do the most common, either for neck or shoulders, so that everybody can see what it looks like, and
Okay.
then we
Okay.
can switch roles.
Okay. Do you want to go in a room? You want to do it right here?
Well, let's do it right here, so we can
Okay.
our audience can stay with
Okay.
us.
Okay. I was gonna say that was especially for the pec muscle. That's my main one. Unfortunately, we do not have a door frame here. But you could be my door frame.
Okay.
So if Dr. Orbach's left shoulder is my door frame, so what I usually like to do with patients is at first we're going to do the treatment in the room, right? So I'm going to shorten their pec minor. I'm going to go with the 2 strong fingers or a heavy thumb. We're going to push down, and then you're essentially going to open all the way. So you shorten the muscle, pin the muscle back down, and then you're basically going to stretch it all the way. And it's kind of hard with, I guess that looks a lot better there.
Mm-hmm.
And I need to get worked on, I guess, by using, because that's tender. And then usually what I'll do is, there's multiple pieces of the pie, right? So if we just do the soft tissue on it, you're still going to have to stretch it. And I'll actually go into the psoas with that as well. So usually what I tell patients to do if they're going to stretch their pec minor out is simple. The field goal is good, right? So you're going to go into the door frame and you're going to start basically linear with it. You're going to take a step and you're just going to lean into it. And then if you want to basically make the stretch a little bit more advanced, you could kind of look up and away, because that's going to kind of help open up and you could get a little bit more fibers there. And then what I also like to do too is I usually have them put their arm in 3 different positions. So I'm going to touch back your leg here. I'll say go in the doorway and put your leg low. And then you're going to basically lean your body away, look up and look to the side. And then we're going to kind of go straight in line, lean up to the side. And then lastly, you could go a little bit higher and you're going to rotate your whole trunk away and look up into the side. And when I tell people to stretch, if you guys were high school athletes, everybody's like, "Oh, we're going to stretch our hamstrings. Let me touch my toes for 10 seconds."
Right.
That don't cut it. You at least got to hold that for 40 to 45 seconds, in my opinion, or else you're just not doing anything to the GTO or the muscle spindle.
The GTO being the Golgi tendon organ.
Yep.
Now, why is this strain counter strain so effective? Our muscles and our tendons are in circuit. They're in a series circuit with one another. That means the load is shared equally. So the tendon has two roles. One is it's the rope between the muscle and the skeleton in our big game of tug of war. And two, the tendon is a continuous piece of the muscle with equal share of the load as the muscle develops. So the muscle has what are called muscle spindle cells and contractile proteins. So the muscle is doing this; it's contracting and expanding throughout all activity. The tendon is pretty much a fixed length.
Yes.
The tendon has what are called Golgi tendon organs. There are no contractile proteins, so the tendon doesn't lengthen and shorten. So when we do flexibility, when we do stretching, the muscle can stretch and stretch beyond any threshold that we can imagine. But when the tendon starts, but the tendon is going to share the load of that stretch. So when the tendon starts to fail, just it's fixed length, it can't stretch any further. The tendon sends the brain a shut-off mechanism, and the stretch is over. Right? You guys all with me?
Well said.
Nod your heads. Nod your heads. Okay. So virtual land. Everybody's with me. Good. So then what happens is, like, if we have a neurological mechanism that tells the stretch to end, where do we get past threshold, and where are we able to take it into a therapeutic place? It's rather a static length on the stretch. So what we want to do is we want to employ a neurological trick to shut the Golgi tendon off.
Correct.
Okay. So if I could maybe borrow your arm for a second.
Let's do it.
I'm going to stretch Dr. Ross's arm back this way. This is as far as it'll go. Now, we're not going to have a test of strength here. I'm not going to pull back on it far enough to injure him. He's not going to push so far forward that I'm going to fall off balance and go flying. So we're at a point of maximum stretch and equilibrium, right? So what I want you to do with about 10% of your strength is just push into my hand. Good. Relax. Now, as he contracted, I mean, hopefully you can see this on the camera, that I was able to stretch him back a little further each time. Hopefully you can see that on the camera for those of you in virtual land as well. So as I'm stretching his arm backwards, we reach the end of range of motion. The Golgi tendon organ told the brain enough is enough. And the brain locked it all down. By contracting and moving in the opposite direction with enough strength to have muscle contraction, but not enough strength to throw me off balance or to injure himself. Anywhere from 10 to about 50% of somebody's strength is ample plenty to make the technique work.
Yes.
We've disabled the Golgi tendon organ, and we're enabling us to stretch back just a little bit further in that range of motion. And that's what's known as assisted stretching, proprioceptive neurofacilitated PNF stretching.
Take it easy.
Thank
See,
you so
George. Yeah, and you're truly gonna get the most bang for your buck doing that. So, like, in my opinion, when you do some of the more advanced stretch techniques, that's when you're gonna actually basically get to the end range, and you're gonna actually just feel optimal as you can. Not to dog any kind of just passive, I'm going to go down, touch my toes, and stretch my hamstrings. But if Dr. Orbach does the PNF stretching with me or any kind of pin and stretching, I'm going to get way more range of motion. It's going to be better for my muscle, and it's going to take load off my spine and different extremities as well.
Right. And once again, there are so many businesses and clinics and modality places and wellness centers where they're doing this PNF stretching, and they're probably doing a pretty good job of it. And it's a fantastic standalone technique. But we're looking at it as both a flexibility technique and diagnostic to determine, is there more that we can do or should do for this specific anatomical place for this joint, muscle, tendon complex.
Absolutely.
So I have no more questions of you. Do you have any?
Yeah,
of me?
I think I'm good. Did we
How
ramble
about
enough?
you guys?
Yep.
Questions, comments, moral outrages,
Yeah.
letters to the editor,
Yeah. So that
virtual land.
yeah, that was me and Dr. Orbach's stretching spiel.
Yeah, we can
Spiel.
do this
So
again.
yeah, if anybody has any questions, and maybe what we'll do for next Wellness Week,
Yeah,
maybe we'll get the camera in the room and we'll just
throw a portable
you could
table out here if the
yeah,
crowd's big enough.
100%. You could hit my upper extremity, I'll hit your
Alright.
lower extremity,
Sounds like a plan.
and then it's pretty cool because like it's really cool when you actually when you could really see it.
Yeah.
We'll stretch his hamstring,
Yeah.
and then it will only get to we'll even measure the degrees,
Right.
and then we're gonna PNF stretch them, and then I guarantee you're gonna get at least honestly 10 to 15% more degrees of the range of motion. And again, not only is that going to help with the muscle, it's going to help with your function. It's going to take load off your skeleton.
Well, there are quite a few techniques that we do here that if you were a fly on the wall, you would say, "What just happened?"
Yeah.
And the person who performed the technique knows what happened, and the person who had the technique performed to them knows what happened.
Yeah.
But nobody else can see anything.
Yeah.
But this stretching technique opens it up so that if you're sitting across the room, you notice the difference in somebody's range of motion.
So you guys are going to have to tune in to the next Wellness Week, and we should have a table out
And
here.
that's
and
what's known as a teaser, my friend.
and there it is.
All right. So we look forward to seeing you all at the next Wellness Week. And perhaps we'll see you as patients between now and then. Thank you so much for the kind